Hey guys, it's Dr. Courtney Burns, Doctor of Nursing Practice, and welcome back to the NP Consult. I thought it might be kind of fun and relevant to do a video over influenza. I know we probably think that influenza is common and we've seen a lot of it, but there has been a new treatment that's come out for influenza, so I thought it might be a good idea just to kind of talk about it. Also, it is peak flu season here where I'm at and also in the Northern Hemisphere, so I thought it was relevant to that. Also, this new coronavirus that's come out at the beginning of 2020, there's been a lot of hype about it, so I thought we might as well talk about a virus that's been around for many years and has been killing thousands of people annually here in the United States and also across the world. And there can be some similarities on this new coronavirus and how it's kind of shifted from animal to human, and the flu virus does that occasionally, so I thought we would just go ahead and do a video on influenza. And I also don't have any financial disclosures, so I'm not being paid to talk about anything in this video. Like I said, the flu season is high right now, and I'm seeing a lot of flu patients, so I'm sure a lot of you guys are seeing a lot of flu patients right now, and it's expected to stay that way for several weeks. Influenza is around all year long. However, it's really, kind of starts increasing around October and peaks sometime between December and February. It can go as long as May, and even last season it was extended out to May, so it can last for a long time, but generally it peaks somewhere between December and February. And the flu can bring us a lot of symptoms. Sometimes we can have mild disease all the way up to pretty severe, and the majority of people that get pretty sick from the flu are either patients that are older than 65 or younger than 5. Maybe they are immunosuppressed for some reason or have some underlying chronic conditions. The flu can really worsen those underlying chronic conditions like asthma, COPD, diabetes, heart disease. It can also cause organ damage, organ failure. It can cause cardiomyopathy, so it really can be pretty severe in a lot of patients. And last season, 35 million patients were diagnosed with influenza, or we thought had the flu. And also out of those people, about a little over 35,000 people did die from the flu last year. But if you compare that to the season previous to that, there was about 61,000 patients that died from the flu in the United States. So, people are definitely getting pretty sick from influenza and unfortunately are passing away. Like I said, the symptoms of flu can definitely vary. We're usually looking for a sudden onset of symptoms. Most of the time patients are gonna have fever, but not all the time. Not all patients are gonna have fever, and most patients that don't have fever are patients that might be immunosuppressed, immunocompromised, really, premature babies or really young infants, and especially elderly people. Though those people may not have fever when they have the flu. It can also bring myalgias, body aches, headaches, URI symptoms like nasal drainage, congestion, cough, sore throat. It can make us feel really tired, and also we can have some GI symptoms, but most of the time the young children are going to be the one that has GI symptoms, but not always. And the flu is spread by droplets from person to person. Sometimes it can make a shift from animals to humans, which we'll talk about in just a little bit, but for the most part, it's spread person to person through droplets. It can be spread by objects like, through contact, but most of the time it's spread through droplets. And about 3 to 11% of the population in the United States each year does get influenza. The most common people to get influenza are children, and the least common people that get the influenza are patients older than 65, and that's according to a study that came out in the Clinical Infectious Disease Journal. And symptoms generally will start about 2 days after a patient is exposed to somebody with the flu. It can be anywhere from 1 to 4 days, but most common is going to be 2 days for someone to start showing symptoms after they've been exposed to somebody else with influenza. And again, it's going to be most severe most of the time for patients that are over 65, less than 5, pregnant patients, patients that are already immunocompromised or have those underlying chronic conditions. I do want to talk a little bit about antigenic drift and antigenic shift. So I just thought this was kind of, interesting information and also kind of relevant for what's going on right now. So viruses like the influenza virus have small proteins on the outside or antigens that our body can kind of recognize, our immune system recognizes it and can build up antibodies so that way we can fight the infection. So constant little mutations or drifts in these small proteins or antigens on the outside of the virus make it very, very difficult to make a vaccine for it, which is why we're constantly having to reevaluate our vaccine and make one annually. And it's also why we can get the flu more than one time. Now, very rarely, but occasionally, the virus will do an antigenic shift. So whenever this shift happens, and this only happens with the influenza A virus, so it doesn't happen with the influenza B virus, but only with A. And those small little proteins or antigens actually kind of develop new ones that are completely new to humans, and we have absolutely no immunity to these. Our immune system just doesn't recognize it. And so that's usually when it does go from animals and kind of gains the ability to then infect humans. And this doesn't happen very often, luckily. The last time it did happen was in 2009 with the influenza A, H1N1 or swine flu. And I was working as a nurse at that time and do remember a lot of really sick patients in the intensive care unit that year from the swine flu. And that is when the virus, the influenza A virus, can cause pandemics. And luckily, we've only had 4 times that this has happened over the last 100 years. So it doesn't happen very often, but it does happen. So we'll talk a little bit about the vaccine, because the vaccine is really the only way that we have to protect ourselves from influenza besides washing our hands and just kind of staying away from sick people in general and maybe not touching our face. So the vaccine is really indicated for everybody age 6 months and older. So we should be offering that at every routine visit during flu season. We should be offering it by the end of October for sure, but definitely ideally before the flu is actually actively circulating. And just keep offering that vaccine, while the flu is active and you still have them, because we just want to make sure that we get as many people protected as possible. And the effectiveness of the vaccine really is going to depend on the patient that's getting it and how healthy they are, or what chronic conditions they may have, or what's going on at the time. Also, the flu virus that's circulating that year, and if our match for the virus was a good match in the vaccine for that year that's circulating, those things will all kind of determine the effectiveness of the vaccine. The World Health Organization meets every year in February, so they're going to be meeting this month to kind of discuss the next year's flu vaccine, because it does have to be manufactured ahead of time. And the best time to get the vaccine, like I said, is ideally, by the end of October or before the flu is actually circulating. We really don't want to get the flu vaccine in July or August because it can wane over time or over the season. But if we do get the vaccine early, it's not really recommended at this time that we revaccinate anybody. So that usually always comes up is, oh, do I need another vaccine later on in the season? And at this time, they really do not recommend that we give any patients, revaccination for early vaccination. And if you get the vaccine in September or October, it really should last you the whole season. So we really don't want to be worried about that as long as you don't get it too early. Also, you do want to make sure that you are giving those young patients that are 6 months to 8 years that have not received the vaccine previously. They do need 2 vaccines. So you just want to make sure that you are going ahead and giving that first one as early as possible in the season, so you can go ahead and give their second one as early as possible as well. We'll talk a little bit about patients that have an egg allergy, because that also tends to come up all the time. Patients are like, oh, well, I have an egg allergy, so I can't get the vaccine. And the majority of people that do have an egg allergy or an intolerance to egg can get the vaccine. So if patients have had any reaction, allergic reaction or intolerance that is anything hives or less, then it is recommended that they can go ahead and still get the flu vaccine. If they've had a reaction that is more than hives, so something like angioedema or respiratory distress, nausea, vomiting, or if epi had to be used, those patients actually still can get the flu vaccine if they've had those reactions from egg in the past, but they really should be monitored in an office setting that has, resuscitation equipment. So if you feel brave enough to give these patients the vaccine in your office, as long as you have the equipment, then you are totally fine to be able to give them the vaccine. If they've had anything more severe than that, which there's not probably going to be a lot more things that are more severe than that, but if you've had a severe reaction more than the angioedema, respiratory distress, then you really probably should not be getting the flu vaccine. Patients that have had Guillain-Barré within 6 weeks after getting the vaccine, that's really a precaution. So it's not a complete contraindication, but it is a precaution for the vaccine. So if they have had Guillain-Barré within 6 weeks after the vaccine and they're generally healthy, have a low risk from the flu, then you really probably should not be giving those patients the vaccine. If they did have a really high risk and you wanted to do it, then you could give them the vaccine. Though they may not respond to it as well, but some effectiveness is better than no effectiveness. So it's still a good idea to give them the vaccine if you feel confident to do that they would benefit from it. Some, complete contraindications from the flu vaccine is pretty low, and it's basically just if you've had a severe reaction to any component in the vaccine in the past, then you should not receive the flu vaccine in the future. The live flu vaccine is a little bit different. It has a little bit more contraindications. So if you are giving the live flu vaccine in your practice, then you're going to want to think about a little bit more contraindications. So patients that are children or adolescents that are getting aspirin therapy or therapy with salicylic or salicylate, then they probably are not going to be able to get the live vaccine. Or children that are aged 2 to 4 years old that have asthma or have had, parents report that their child has been wheezing over the last 12 months or last year. If they reported that at all, then they should not get the live flu vaccine. If patients are immunosuppressed or they're in close contact with patients that are immunosuppressed, and they also probably shouldn't get the live flu vaccine. If they are pregnant or have received an antiviral in the last 48 hours, then they should not get the live flu vaccine. We'll talk a little bit about flu testing because we're all probably doing a lot of flu testing. And if you're in office, you're probably using the rapid flu test, which is really convenient because we can get the results in less than 15 minutes usually. And it's pretty easy to do and can be done in office. However, the downsides of the rapid testing, which is, like I said, probably what most people are doing if they're doing it in the office or in primary care or urgent care, those kind of settings, the downside of it is it's not, really 100% accurate. You can definitely get some, false negatives and false positives. So you can get more false positives on the rapid testing when it's when the flu activity is low out there. So kind of at the beginning of the season or end of the season when the activity is kind of getting lower, you can get a lot more false positives. And then when the flu activity is pretty high, so like right now when we're testing a lot of people, we actually can get a lot of false negatives. So you just really don't want to go off of the flu test by itself to, kind of decide if you want to go ahead and give treatment. So confirmation of the flu on testing is really not required for any decision making to go ahead and treat them for the flu. If they have the signs and symptoms and the flu is circulating, then you can just go ahead and treat them for that because we really don't want to delay that for any reason or, not give them that if they could have had it just because the test is negative. Also, if the patient has had the seasonal flu vaccine that year, it still doesn't rule out that they could possibly have the flu. So you still could, test or treat those patients. And we also can use the flu testing to kind of help us figure out, if there's something, more going on, or do we want to do antiviral treatment or antibiotics? The reason why I say antibiotics, which antibiotics we all know does not treat the flu, I have had some patients over the last couple of weeks that have come in just complaining of a lot of bacterial rhinosinusitis symptoms, so teeth pain, sinus pain, lots of nasal drainage congestion, and they've had these symptoms for over 2 weeks, and then they will tell me that last night they worsened with fever, body aches, chills. And those patients, I'm probably going to go ahead and flu test, because I just want to make sure, like, you know, have we come in contact with the flu, and now we have that on top of our bacterial rhinosinusitis. So you could still treat those patients with antibiotics, but they may not be feeling better, you know, quickly with that, because now they have the flu and are going to feel pretty bad for the next 7 to 10 days. So it's just, you know, one more piece of information that you can kind of tell the patient that, yeah, we might be treating your bacterial sinus infection with this antibiotics, but you're not really going to feel completely better while you have the flu. Also just kind of trying to decide, like, well, this patient is, you know, 5 or 6 days in and they're really not feeling better, but they are kind of alluding to the fact that maybe they need antibiotics. And if you can kind of prove to them that, no, we really think this is still viral and this is the influenza virus, and, you know, maybe that's why you're not feeling better in, you know, quite yet. And we really just have to consider a number of factors when we're interpreting these tests. Like I said, you know, just the duration of how long the patient has been sick, because it really is going to be more accurate at the very beginning of their symptoms. And that's when we really are mostly going to want to know when the patients have influenza, so we can go ahead and treat them. But again, a negative test does not rule out that they do have influenza, or possibly still could have it. So you just want to go ahead and make sure that you keep that in mind. Treatment for influenza, we really want to go ahead and start it within the first 48 hours. So after that, it's really not going to be beneficial for the patient. So I tell my patients that you really kind of want to come in as soon as your symptoms start if you think you may have the flu. But a lot of patients can stay at home, and as you know, if they're, you know, generally healthy and they don't really feel overly sick, they can get over influenza without treatment. So you can also tell your patients that they can stay home, you know, stay away from other people so they're not spreading it, and just make sure that they're drinking a lot of fluids and resting, taking care of themselves, and then coming in if they just are feeling overly sick or just are not getting better. But if they do come in within those first 48 hours, we can offer them influenza antiviral treatment. So that's when it's going to be most beneficial. And also, you know, it can reduce, you know, possibly their hospital risk, or even possibly risk of death if they are treated. And patients that are going to be, you know, more benefit from being treated are going to be those patients that have those underlying conditions. So like the asthma, COPD, diabetes, heart disease, patients that have a BMI of greater than 40, or have kidney or liver disorders, then they're really going to probably mostly benefit from being treated with antivirals. So we'll talk a little bit about Tamiflu, but Tamiflu has been around for a while now, so most people are probably pretty, you know, knowledgeable on Tamiflu, but it is, you know, either in pill or liquid form, and it's FDA approved to treat influenza for early treatment in patients that are 2 weeks and above. So 14 days and older can be treated with Tamiflu, and it is prescribed twice daily for 5 days. It's also prescribed for can be prescribed for prophylaxis in patients that are 3 months and older, but we'll talk a little bit more about prophylaxis here in a minute. The most common side effects are nausea and vomiting, and it's the recommended treatment for patients that are pregnant. So again, it's recommended for pregnant patients, Tamiflu is, because it really has been studied the most in that population, so they can do it for you know, for pregnant women, so it's safe and beneficial. The new treatment that's come out for influenza is called Xofluza, or I'll see if I can say it, Balaxavir. And it's actually really, really nice because it is only a one-time dose of medication. So, you know, I'm sorry about Tamiflu that's twice a day for 5 days, but now we have Xofluza that is once a day. Or I'm sorry, just a one-time dose. And I really wouldn't feel bad for Tamiflu, because the company that owns Tamiflu also owns Xofluza. And right now, Xofluza is only indicated in 12 and older. So for those patients that are 14 days to 12 years, then, or I guess 11, then you can go ahead and of course still use Tamiflu right now. But for those patients that are 12 years and older and that are, have a non-complicated, flu, those patients can get
Xofluza.
Patients that are pregnant or breastfeeding, it's not recommended that they use Xofluza. It's not really been studied in those populations, so it hasn't really been studied in pregnant women, breastfeeding women, or in patients that really have complicated illness. So those patients are probably gonna need to be treated with something else. And it's really best to be given within that first 48 hours again. And you can take it with or without food, but you really don't want to take it with calcium, so like dairy products, calcium supplements, iron supplements, or magnesium supplements. It's not recommended that you take the Xofluza with that. So I did go to a talk over Xofluza and kind of listened a little bit about it more, and it does seem like it's a pretty interesting antiviral. It goes into our body and kind of goes into the cell, and when the virus goes into our cell, it just doesn't allow the virus to go back out so it can replicate. So it just kind of keeps it inside. And patients that I've given it to definitely do think that they feel better faster with the Xofluza. It did come out last flu season, so we had it last flu season and now this flu season. So if you haven't given it a try, I definitely would go ahead and try it. If you don't have samples of the medication, there is a coupon that the patient can pay $30 for the medication, or possibly less, maybe more, but it takes off $60 of the medication cost. And most common side effects from it, the company has said that the most common side effects they saw were bronchitis, nausea, diarrhea, sinusitis, and headache. So the last thing I really just want to talk about was prophylaxis, because for the last few years, I mean, really probably 5 years or so, the CDC has not recommended that we do prophylaxis medication, for the flu. So if you diagnose somebody with the flu, a lot of times what they're going to say is, okay, well, what about my son, or what about my husband, or grandparent, or whatever. They do not recommend that we go ahead and give these patients just treat them prophylactically for the flu, but it may still be a good idea to obviously let them know, like if they're sick, then they can come in as soon as possible and go ahead and get treated, but they don't have to take the medication before they're having any signs and symptoms of the flu. And basically just want to tell them to go ahead and seek, medical care as soon as possible, but they really don't have to be given the medication before they get the flu. So hopefully that gave you guys some information about influenza and a little bit about the treatments for it. Like I said, I really don't have any financial disclosures for any of the medications that I've talked about here on the video. All of this is just, from personal experience, and the information in this video did come from the CDC, and I will go ahead and try to link go ahead and put a copy of the link to the CDC's website on influenza, but the information in this video did come from that website.